I just wanted to start off by thanking the organizers for inviting me to present at this conference. I'm actually going to be talking about quite a controversial subject, MRD as an endpoint for frontline therapy, and I'm going to say no, we're not ready for this for prime time. Here are my disclosures. So what exactly can MRD provide? It provides a snapshot of the depth of response at a specific time point. It doesn't tell us anything about safety, toxicity, or death. Do we really know when the optimal time point to evaluate MRD? I don't think so. I think the time point is undefined. I may want to do a bone marrow biopsy on a patient to assess MRD at 1 month or 3 months post therapy, and my colleague may want to do it 1 year post therapy. So we have to keep that in mind that nobody really knows when the right time to do MRD testing is. There's also a sampling error due to focal disease. For example, think about when you went through CAR T. 1 month post CAR T, we always want to do an MRD testing. And these patients are cytopenic. So is it possible that they're really MRD negative, or is it because of the cytopenias, we don't actually have a lot of cells to tell us if they're truly MRD negative? A single measurement MRD may not actually be optimal. Multiple samplings are usually preferred, and what we want to achieve for is sustained MRD. Because we have some patients who achieve MRD negativity, but they relapse early. So MRD may not be the right endpoint for all patients. And like I said, maybe sustained MRD may be a better endpoint. Some patients actually achieve a CR, but they're not MRD negative. And if we only use MRD negativity, these responses are lost. So sustained remission, but MRD positive, we know is well documented. One more thing is that MRD may not always correlate with survival. For example, think about the Bellini trial. In this study, they used patients had venetoclax, Velcade, and dexamethasone compared to a placebo arm where it had placebo, Velcade, and dex. Even though it showed that MRD was much deeper in the venetoclax arm, we saw the FDA put a partial hold on trials involving venetoclax in March of 2019 because of the high death rate observed in the patients with the venetoclax arm. So what are some fallacies of MRD testing? We know that MRD testing is useful for prognosis, assessing the efficacy of new treatment approaches, and even drug approval. As you know, most clinical trials now either have a primary endpoint or secondary endpoint of MRD testing. However, treating patients to MRD negativity is still not ready for prime time. We need to learn how to tailor therapy and create prospective trials where we're treating to MRD negativity. But so far, all progress in survival outcomes in myeloma to date has resulted from new drugs. What exactly is MRD and the depth of MRD testing, right? So minimal residual disease, as you know, is a small amount of cancer cells that still remain in the body after treatment. So for example, as you can see in this table, if somebody's in CR, they have 1 cancer cell in 1,000 myeloma cells. They also don't have any monoclonal protein, and their bone marrow has less than 5% plasma cells, and it's not monoclonal. And when you move to stringent CR, you actually see 1 in 10,000 cells. And here you also know that the kappa lambda ratio is normal. But what gets tricky is when you get to MRD by flow cytometry and next-gen sequencing. You're getting deeper and deeper responses. For example, for flow cytometry, you're looking at 1 cell, 1 cancer cell in 100,000 myeloma cells. And for next-gen sequencing, you're looking at 1 cell in 1 million cells. Each testing method has its own limitation. For example, when you're doing a flow cytometry MRD, you're thinking about you're doing a bone marrow biopsy. If you're not giving the first pull, which has most of the cells, then you may dilute the sample because you may be sending 1 to FISH, 1 to cytogenetics, 1 to MRD for your local lab, 1 to MRD for the clinical trial. So you have to think about sampling and when is the best time to draw that sample for MRD. And then when you look at next-gen sequencing, what's important is that you actually need to have a baseline clone. So we have to hunt down the patient's initial bone marrow so we can have the clones detected that we're following over time. And if somebody comes in as a referral, it may be hard to always have a baseline clone available. And as we talked about sustained MRD, why is that important? And what is sustained MRD? So sustained MRD is defined as a maintenance of MRD negativity for more than 1 year without the loss of MRD negativity. So for example, in this ALCYONE trial, you can see the DARA was added to VMP compared to VMP, and you see that there were higher rates of sustained MRD negativity. This is quite important because we don't want to just assess one time point. Rather, we want to look at multiple time points and see that these MRD is sustained. Here, we're going to briefly talk about the biology of MRD cells. Myeloma is a very heterogeneous disease, so it's important not only to monitor MRD, but also try to understand the biology of the MRD cell and the microenvironment surrounding it. Right now, everybody does MRD, and it's used as a prognostic marker, like we talked about, rather than learning from this MRD. What about if you have an MRD positive patient? Wouldn't it be better if we had a deeper dive into this genetic makeup of this clone and you figure out how you change the treatment to target that specific clone to treat it to get to MRD negativity? So Costa in ASH of 2019 actually discussed their master trial, and they designed it in a way where it's a prospective way to get to MRD negativity. And it's one of those first trials that actually doing that, and it'd be interesting to see what that data shows. Here we're going to talk about one case study of a patient who we treated, but not to MRD negativity. It was a 77-year-old male who presented with myeloma 20 years ago and had IgG kappa myeloma. So as you can see, for first line, the patient underwent VAD therapy with MEL-200 transplant and was given interferon alpha maintenance for 3 years. And despite having the persistent M spike, he had an M spike of 0.5, we stopped therapy after 3 years of treatment, and he had 9 years of no treatment with this persistent M spike. When he relapsed in 2010, he was enrolled in a clinical trial with elotuzumab, Revlimid, and Dex. And you can see that he was on this trial for 6 years and did really well, but he never completely cleared his IFE. He was still IFE positive. But at the end of 6 years, right here, we stopped therapy because the patient was having increasing fatigue. But surprisingly, the patient converted to IFE negativity post discontinuation a year later of this therapy and continued to stay IFE negative and MRD negative. So here's someone who was treated with the goal to achieve MRD, here's someone who was treated with the goal of not achieving MRD negativity, and the patient did fine and is continuing to do fine. When we talk a little bit more of the disease biology, we have to understand that we have to be a bedside doctor who approaches each patient individually. It's important to understand the biology of these patients' diseases. For instance, in the MRC trial, you can see that there's patients that had favorable cytogenetics versus adverse cytogenetics, and the patient who was actually MRD positive but had favorable cytogenetics did better than the patient who was actually MRD negative and had adverse cytogenetics. So the adverse risk factor actually overrides MRD negativity, and those with adverse risk factors but that are MRD negative still relapsed. Therefore, the point here is that one-time MRD negativity is not enough, and that's why sustained MRD is more important. As we discussed in the previous case where we talked about the patient who was treated not to achieve MRD negativity, there are patients in prolonged remission with residual disease, and we think it's because of this MGUS-like phenotype. A small number of residual tumor cells may persist under control in the immune system for a really long time. And what happens here, and as you can see on the slide, there's some patients who develop this MGUS-like profile, and as you can see, the outcomes are really good. Despite being MRD positive, they have a very good outcome. Another thing to really look at is the prognostic value of immune reconstitution. Here you can see that when you are MRD positive, you have clonal plasma cells. And when you're MRD negative, you have returned your normal immune reconstitution and you have normal plasma cells. But we have some patients who are MRD positive and that are actually recovering their normal immunoglobulins, meaning their normal plasma cells are coming back. And these patients act very similar to patients who are MRD negative. they recover their immunoglobulins and their microenvironment changes back compared to those patients who didn't recover. And these patients tend to do really well. So another thing to look at is there is an importance in the prognostic value of these immune reconstitution and understanding that they have a favorable immune profile despite being MRD negative. Despite being MRD positive. Finally, we wanted to talk about another case where this is a CAR T patient who had a lot of lesions prior to CAR T, including this mass in his jaw, and had an M spike of 1.5, had 80% cellularity in his bone marrow with plasma cells. And this patient was treated with CAR T cell therapy, and you can see post CAR T therapy, he recovered completely and he went to complete remission with no M spike and no lesions found on PET. However, in August of 2019, he presented with proptosis and he had trouble with his vision. So what we did is we did another PET scan and a bone marrow biopsy to see if he relapsed. Surprisingly, his bone marrow is completely negative. His M spike was 0, but then he had a small mass near his eye. So what this tells you is we can't just look at MRD negativity. We actually have to be a bedside doctor and make decisions based on your patient, just not on one test. So in conclusion, should MRD really be the endpoint of therapy? I don't think so. Nothing I've shown you today shows that we're ready for prime time. If you're MRD negative, can you really stop treatment? I don't think so. Achieving MRD negative at one time point is a surrogate for cure? Definitely not. As you can see, patients still are MRD positive and almost in an MGUS-like phenotype, and they've been cured. If a patient converts from MRD negativity to MRD positive, do you need to try therapy? No, there's actually no data that tells you that if you're MRD negative and now positive, changing therapy is going to change the prognosis of the patient. You need MRD for day-to-day management decision? No. So what is MRD really good for and useful for? So far, I think for prognosis, assessing efficacy of new treatment approaches, and drug approval. Thank you.
Good morning. I am presenting to you today about the role of continuous therapy in elderly multiple myeloma. Well, I'm going to present you my answer right away from the upfront, so that way if you're busy or if you have to run somewhere else, you don't have to wait till the end of the talk. Does continuous therapy improve outcome in elderly multiple myeloma? The answer is yes. In French, eh bien sûr que oui, and even in Italian, certamente. So here you go, you have my statement about that. What is the data I'm going to use to back up these statements? Or actually, what have we learned over the past 2 decades about treatment of elderly multiple myeloma? I think, first of all, we all agree that the goal is to maximize the rate and durability of MRD negative disease without increasing toxicity. And that will hopefully lead to improved survival outcomes. And therefore, the paradigm I'm showing below: induction therapy, maintenance, again with the goal to induce deep responses and improve MRD negativity. Over the past 2 decades, we've been fortunate to have a large number of clinical trials assessing variable combination therapy and variable regimen in elderly transplant ineligible multiple myeloma. So what have we learned? We had 3 randomized trials looking at combination of 3 drugs versus 2 drugs, what we call triplet versus doublets, and these include VMP versus MP, the VISTA trials. There have been several trials by the French and Italian groups looking at NPT versus MP, and more recently, Dr. Dury compared VRD versus RD. And all these trials is clear evidence that triplet is better than doublet, in particular if you combine a proteasome inhibitor and immunomodulators. What else have we learned? Many trials look at the comparing continuous therapy versus fixed therapy, which is the subject of this debate. And I listed a few trials in here. The first one is the MM015 trials that compared melphalan prednisone Revlimid, or MPR, followed by Revlimid maintenance, versus MPR with no maintenance versus melphalan prednisone. The second study was VMPT with maintenance Velcade thalidomide or continuous Velcade thalidomide versus VMP without continuous therapy. And a similar design of the VISTA trial also assessed VMP with VT and with a historical comparison with the VISTA VMP arm. And more recently, the first trial was reported, and that looked at the comparison of RD versus RD for 18 months versus MPT. This is the first trial. And most recently, the Myeloma 11 trial compared Revlimid maintenance versus observation in transplant eligible, but also in transplant ineligible. In all these trials, there is evidence that continuous therapy is better than fixed duration therapy, and we'll talk about this in more details. So building on this paradigm, and more recently with the advent of monoclonal antibody targeting CD38 with daratumumab, two large trials also compared continuous therapy with daratumumab VMP versus continuous VMP, the ALCYONE trial, or daratumumab with RD versus continuous RD. So I guess the schema is fixed. Continuous therapy is here to stay because even with novel therapies, we're comparing continuous versus continuous regimens. And even moving forward, we're comparing now a quad therapy versus triplet therapy in a continuous type of regimen. This is daratumumab VRD versus VRD, which is the Cepheus trial that we're still awaiting the result of this study. So what are the arguments in favor of continuous therapy, or the yay vote, as we say in North America? The first argument is the depth and duration of response does improve with continuous therapy, and I'll show some evidence in support of that. Also, survival outcomes are better with continuous versus fixed duration therapy. And lastly, the depth of response and the improved progression-free survival and overall survival in some trials does improve the quality of life and decrease morbidity by delaying the relapse. So what is the data behind these arguments? One analysis of the first trial that I performed in collaboration with my co-investigator on the first trial, we looked at the role of RD continuous versus RD 18 month. And as you see in the panel on the right side, RD continuous improved the depth of response, in particular after 18 months of therapy. If you look at the last bar where the blue arrow is pointing, you can see that 13% of the patient improved the response to VGPR after the initial 18 months of therapy. In addition, this improvement in response that result in deepening of the duration of the response. As you can see in patient achieved complete remission, RD continuous improved the duration of response by nearly 1 year compared to RD 18. This was also seen in patient in VGPR as well as in patient in partial response or PR. Therefore, continuous therapy does deepen the response over time and improve the duration of response. But how about survival outcomes? This is the most important parameters. In particular, how about progression-free survival, which accounts for disease relapse and also death? Looking at the 4 trials I mentioned earlier, starting with the first trial in the upper left panel, you can see that in this trial, RD continuous significantly improved progression-free survival in comparison to RD 18 and MPT in all comers in the intent to treat analyses. When you look at responding patient, RD continuous significantly improved progression-free survival by nearly a year. Similarly, in the Italian trial with VMPT-VT versus VMP, the continuous therapy also improved median progression-free survival by nearly a year, 35.3 months versus 24.8 months. And the MM015 trial, MPR, also improved median progression-free survival by nearly doubling the median progression-free survival from 14 months to 31 months with continuous therapy. And most recently, with the Myeloma 11 trial, the median progression-free survival also doubled in the transplant ineligible population from 11 months with observation or no continuous therapy versus a 26 month with continuous therapy. Therefore, we have many trials showing evidence that continuous therapy improves progression-free survival versus a fixed duration therapy. And I would really be amiss if I don't mention the 2 recent trials that included novel monoclonal antibody targeting CD38, the MAIA and the ALCYONE trial. While the MAIA wasn't really a design of continuous versus fixed therapy, practically it ended up being so because RD that therapy was limited, while DRD was continued significantly longer compared to RD alone. And in this study, as we all know, DRD significantly improved progression-free survival to an unprecedented level in this population. Similarly, in the ALCYONE trial, where DARA VMP was given for 9 months and daratumumab was continued indefinitely until disease progression after that, versus fixed therapy with VMP alone. Here also we see that the daratumumab VMP with the continuous therapy arm doubled the progression-free survival from 19.3 months to 36.4 months. Therefore, we have plenty of evidence that fixed duration therapy does result in inferior progression-free survival, meaning higher relapse and higher death. Well, how about the argument that by using continuous therapy, you end up causing more side effect and the quality of life is worse? And there is merit to this statement. However, studies done to address this question didn't show that. If anything, the analysis performed by Delforge and colleagues from the first trial showed that the continuous therapy, if anything, improved the health-related quality of life and PROs, as shown in this analysis. Also, a similar analysis was performed on the MM015 trial by the Pawlyn and colleague, also did not show any worsening of the quality of life with continuous therapy. Therefore, the argument actually in favor of continuous therapy to improve quality of life. So what is the argument against continuous therapy? What is the mathematical model behind that? I tried to schematize this in this graph shown in here. On the y-axis is disease burden, on the x-axis is time. Clearly with continuous therapy, you can see a decrease of disease burden over time. The argument for those who favor intermittent therapy or fixed duration therapy, that you can stop therapy at a certain time point, wait for disease relapse, and reinstate therapy at that point. And you can always reinduce remission and always reinduce deep remission to mimic that achieved by continuous therapy. That's possible. However, there's many assumptions for this model to hold true. The first assumption that all patients at relapse will be fit to receive salvage therapy. And this is what we call attrition rates. Attrition rates is non-existing in that model. The second assumption, the disease biology remains static, meaning there's no clonal changes at disease relapse, there's no additional mutation, there's no acquired resistance at relapse, and responses are similar at first, second, third relapse. And again, this is an assumption. And lastly, the third assumption, which we already addressed previously, that the quality of life is similar between fixed therapy and continuous therapy. We know that this assumption isn't true because the quality of life is better, or at least not worsened by continuous therapy. So how about the attrition rate, the first assumption? Several studies looked into this, and the most eloquent study performed by Dr. Ki Young recently actually showed a significant attrition between first line of therapy and second line of therapy. Nearly 30% of the patient never get the opportunity to receive second line of therapy when they relapse for variable reasons, whether for existing comorbidities, acquired comorbidities, or disease-related complication. Therefore, it will not be prudent to stop therapy when it's effective and wait for disease relapse, because nearly a third of your patient may not have the opportunity to receive salvage therapy at relapse. The second assumption is that the disease biology remains static at disease progression or at relapse. This is a question that has been bugging many of us, and we're hoping to address in variable genomic studies. Eloquent work performed by Jonathan Keyes from the COMPASS trial showed an alarming finding. He reported that nearly 30% of the patient changed their genomic signature at the time of relapse. In particular, 28% of the patient acquired a proliferative signature at the time of relapse, and this is clearly associated with worse outcome. Therefore, the best would be to avoid relapse and not allow the clonal proliferation and acquisition of the signature at relapse. So what are the arguments that my colleagues use against continuous therapy, or the nay vote? Well, the first argument, there is no improvement in overall survival with continuous therapy. The second argument, continuous therapeutic pressure will lead to emergence of resistant clone at relapse and worse survival outcomes. And the argument we heard for a long time, deferring effective therapy for later, save your penny for dark days, I guess. And lastly, that increased toxicity and possibly second primary malignancies is worse with continuous therapy, and obviously financial toxicities, which is hard to argue against in this context. But how about the key argument there is no improvement in overall survival with continuous therapy? Well, this statement is simply false, I would say. We've learned from the Italian trial with Antonio Palumbo that VMPT followed by VT or continuous therapy versus fixed duration therapy with VMP does improve overall survival. 5-year overall survival, 61% with continuous therapy on this study versus 51% with fixed duration therapy. And more recently with the ALCYONE trial, data VMP with continuous therapy significantly improved 3-year overall survival, again in favor of continuous therapy. So we have 2 studies clearly showing improvement not only in progression-free survival, but also overall survival with the use of continuous therapy. But how about the first trial? The first trial was one of the large hematological studies in multiple myeloma. That study showed progression-free survival, but no overall survival. My answer is read the fine print. In particular, if you look at the overall survival, you clearly note that continuous therapy RD was clearly superior to MPT and improved overall survival significantly. And actually, that's not surprising because the study was powered to show difference in progression-free survival and overall survival between RD continuous and MPT, but not between RD continuous and fixed duration RD of 18 months. And I put there the statement from the paper regarding the power design. The second key element is in multiple myeloma, we have multiple salvage line of therapy, and it's very hard to account for the impact of subsequent line of therapy in overall survival. And Dr. Thierry Facon actually performed a very eloquent analysis of the first trial, and he looked at the subsequent line of therapy received by the patient on this trial. And surprisingly, as you note in this table, there was difference in the subsequent therapy received between patients who were treated with continuous therapy versus fixed therapy with RD18. In particular, I'd like to point out that a large number of patients who were progressing on Revlimid-based therapy RD continuous received thalidomide-based therapy with thalidomide single agent or MPT, which is clearly an ineffective regimen in this context. And therefore, you can see that in this context, the overall survival was significantly worse for RD continuous, 52.9 months versus 62 months with RD18, because in the RD18, these patients were progressing off therapy. And in a similar pattern as well, other therapies were received differently between the RD continuous and RD18. There was a significantly larger proportion of patients who received carfilzomib-based therapy with RD18 versus RD continuous. 12% received carfilzomib-based therapy versus 2% with RD continuous. And therefore, you can see as well that the median overall survival in this patient population received carfilzomib-based therapy largely with RD18 was significantly better, 79.1 months versus 41.1 months. Therefore, this difference in the subsequent line of therapy, which is biased in the study in favor of RD18, does explain the lack of overall survival. And indeed, if you look at the patient who received Revlimid-based therapy, for example, and the subsequent line of therapy, the median overall survival appears to be better with RD continuous versus RD18. Therefore, I would state that the first trial does not show a bias against continuous therapy with regard to overall survival. With regard to myeloma 11, in that study, actually, they underestimated the overall survival for the observation arm. The study was powered to estimate an overall survival of around 50% at 5 years, but actually, as you know, the overall survival was closer to 60% in this study. Well, how about the other argument that if you use continuous therapy, you're going to impose therapeutic pressure and you're going to induce novel mutation and going to result in having more aggressive clone at relapse? Studies done by Jones and colleagues from the Myeloma 11 trial did a very eloquent analysis to examine this hypothesis. And as you can see on the table on the left, there was no difference in the gain of mutation at relapse between patients receiving Revlimid, continuous therapy, or observation. They're pretty much identical. If anything, the rate of new mutation was slightly lower in patients receiving Revlimid continuous therapy. And if you look at the number of clone or clusters prior to therapy and then at relapse, it doesn't seem to be different between those receiving Revlimid-based therapy or those on observation. If anything, it'd be slightly higher at relapse than those receiving observation, although it's not statistically different. But most importantly, if the disease is more aggressive at relapse, this will result in a worse progression-free survival 2, PFS2. And in the Myeloma 11 trial, the PFS2 was actually still better for the continuous therapy with Revlimid versus the observation. The median PFS2 for patients not eligible for transplant was 43 months versus 35 months, with a hazard ratio of 0.7, a p-value that's significant, again in favor of continuous therapy and confirming that continuous therapy doesn't result in worse outcome in subsequent line of therapy. So going back again through the MAIA arguments, I showed you that indeed there is overall survival benefit in at least 2 trials, and those that failed to show overall survival were not powered to do so, or there is a bias imposed by the subsequent line of therapy. There is no evidence that therapeutic pressure or continuous therapeutic pressure results in worse clone at relapse and higher mutation rate. The argument for deferring effective therapy doesn't hold. We all know that you should use your most effective therapy in earlier line of therapy because it results in better survival outcomes and better responses. Increased risk of SPM doesn't hold either, because if you look at the first trial, the SPM rate wasn't different between RD18 and RD continuous. So that one, we can strike it as well. Again, financial toxicity, we cannot argue against that. It's clearly higher cost with continuous therapy. So going back to the schema, comparing continuous versus defined, and what do we know? If I haven't convinced you by the data I presented so far that continuous therapy is the paradigm we should adopt and results in better progression-free survival, overall survival, and quality of life, at this point, we're supposed to be in France next week. So I had to reach out to my French colleagues, and really France is the land of the wisdom and land of the philosopher. So I reached out to my inner guts and I asked my French colleagues, what do you think? Is continuous therapy better than fixed therapy? Intermittent treatment better than continuing treatment? And as I was sobering about this argument, a voice came from the land behind, and actually it was Jean de La Fontaine, the famous fable writer. And he told me, haven't you heard about my famous fable, Le Lièvre et la Tortue, or as we know it in English, the tortoise and the hare? And he said, my friend, rien ne sert de courir, il faut partir à point. Or in English, slow and steady wins the race. And or if we apply it to our argument here, steady or continuous therapy wins the race in here. With that, I will rest my case. And until we meet hopefully next year in Paris, thank you for your attention and keep healthy.